What I'm going to talk about today is really a passion of mine and something that I've been sharing on, like Dr. Lum said, for a couple of years and really going deep down the rabbit hole into the data, into what we can do. And so what I want to say to start off is some of this is not very fun to hear, but what I hope to leave you with is not a sense of dread overall, but the fact that there are lots and lots of things that we can do to right the ship in healthcare when it comes to our impact on the climate. And so with that, I'll start with my disclosures. Most importantly, I am not a climate scientist, but I am a contributor to and an observer of the waste we create in the OR every day. And I think every person who works on climate or emissions has a radicalizing moment, and it really came to seeing the waste in the operating room, which was my radicalizing moment, which led me to this. So I'm going to start with a few questions just about reframing how we think about waste, how we think about carbon emissions, and what our relative or perceived impact can be. So if I asked you to think about Los Angeles, it's huge, of course. There's 4 million people in the city, there's 10 million people in the county. And I asked you to think about who's the biggest waste producer in the area. What would you think? Would you think it's my hospital, Cedar-Sinai? We have about 1,000 beds. There's tens of thousands of procedures done every year. Would you think it is something like UCLA campus with 30,000 undergrads and more graduate students coming in and out every day? Or would you think it's some kind of entertainment venue like the former Staples Center, which is now the cryptocurrency.com or something really sad center, but hosts multiple sports teams and millions of people who come through every year? Certainly that creates a lot of waste, right? Or even SoFi Center, which can hold 100,000 people at a time and hosted Taylor Swift and Beyonce back to back and really restarted the LA economy. But putting all this into context, I was really surprised to learn that we are the biggest waste producer in Los Angeles. And at first I found this rather embarrassing. How is this possible? But come to find out, most hospitals are the biggest waste producers in their cities, and that includes big cities like New York and Chicago, and then of course in smaller areas as well. We are overproducing waste relative to everything else that's going on in our city. And so then if I asked you to think about healthcare globally, and healthcare's global impact and what that looked like, and compare it to aviation. Aviation gets lots of scrutinies. In France, they've banned short-haul domestic flights for which there's alternative transportation. There's lots of focus on looking into things like biofuels and how can we reduce our emissions. But healthcare actually creates almost double or about double the amount of carbon emissions as global aviation. We're just getting none of the scrutiny and none of the, I guess, awareness of what we're doing. Similarly, in California, you won't be able to buy a gas-powered automobile, at least a new one, after 2035. If we think about auto manufacturers and what they're doing, no, everything's bad. They're creating a lot of emissions, but the pharmaceutical companies actually create more emissions, more than 10% than auto manufacturers annually. So again, we really just want to reframe our thinking about where carbon emissions are coming from. And because we get relatively no scrutiny, our industry is on track to double our emissions by 2050, as opposed to being in compliance with the Paris Climate Accord, which would be along the dotted line along the bottom. And just as an example, Columbia University set really aggressive carbon emissions goals for reduction by 2030, and they are meeting every single one of those goals in every part of the university except the healthcare system, which is continuing just to blow by goals and increase their carbon emissions. Why? Because there's no scrutiny and there's no accountability. And if you added up our healthcare sector alone, this is a very US American-centric problem. We account for 27% of the global healthcare footprint, despite having only 4% of the world's population, which added up creates more emissions annually than the UK as a country, not their healthcare sector, their country. And so if countries have goals for carbon emissions, certainly our healthcare sector should. And so that's what I want to talk about today. Review our huge impact and actually distill down exactly where it comes from, because when you know where it comes from, that's how we can change it. Discuss the effects on patients, of course, more and more data coming out, and then also the focus on social determinants of health, how we really can't talk about that without climate change mitigation. And then most importantly, I want to spend the majority of the time talking about prompting action, what we can do in our own ORs, our hospitals, our systems, and focus a lot on the OR because that's where I spend the majority of my time. And that's one of the biggest areas of problems in healthcare. But where is our impact coming from? Well, if you look at things like energy, water, and waste, we are the second biggest users of energy of commercial buildings, and that's just after food service, which uses a lot of refrigeration. We're the biggest users of water out of any type of commercial building. That's even much more than things like hospitality, that's washing linens all the time. And then we're the biggest producers of waste. US hospitals create 14,000 tons of waste per day. About a third of that comes from the operating room, despite the fact that the operating room has a very small square footage footprint. A large proportion is plastic waste, single-use plastic waste, a smaller proportion, or should be smaller proportion, infectious waste. And then sadly, some of it is food waste because we do a bad job of proportioning out healthy food for our patients and our staff. The US is also the biggest user of pharmaceuticals worldwide and pharmaceutical packaging, which is actually FDA regulated in a $20 billion industry. So if you think about 3 months of contraceptive pills for somebody who may have to contracept for 40 years, certainly this amount of packaging isn't sustainable. But the biggest area where our impact comes from is what's called the supply chain. And maybe you never heard of this before COVID or wish you would never hear about it again. But the supply chain simply refers to the entire life cycle of an item. And that is the creation of the item from its natural elements, usually petroleum-based single-use plastic, the packaging, the sterilization, the transport, the use of that device, and then the disposal of the device and its packaging at end of life. Supply chain is creating over 70% of our carbon emissions, showing that we simply overconsume products. And traditionally in healthcare, labor has been the biggest expense. It's always been labor, labor, labor. But because of increase during COVID, accounting for more than 2,000% increase in costs for some supplies, supply chain actually became the most expensive. So in healthcare, we're actually spending more money on things rather than people. And as I mentioned, the operating room is really ground zero for this. We use up to 60% of an organization's total supply costs. Again, we're just using single-use supplies. We create a third of the waste and 2/3 of the regulated medical waste, which I'll talk about today. We consume more energy than anywhere else in the hospital. And then there's the unique issues of anesthetic gases and exhaled CO2. So I propose to you that what we're doing in the US in our operating rooms today is not sustainable, and it's a big propellant of climate change. And again, how does this affect our patients? And this is where some of the really unfortunate and depressing data comes in. And you've probably already seen a lot of it, but the way I like to break it down is like this. And I do want to start by talking about, this has been talked about since 2009. It was in 2009 when the Lancet said that climate change is the biggest global health threat of the 21st century. The impacts will be felt all around the world, and not just in some distant future, but in our lifetimes and those of our children. And it's 15 years later, and we still have only gotten worse rather than better. And so a lot of the early data focused on that next generation, the generation of our children, how it's going to impact our children, but that really moved into reproductive health and women's health. And now it's moving into other fields, including other surgical fields and measurable surgical outcomes as well. It's affecting us everywhere. And if you want to think about how to break it down, there are the effects overall, of course, of warming, the effects of heat, the effects of pollution, which can be measured in local pollution like particulate matter and nitrous oxide, and then the effect of toxic substances like plastic particles and endocrine disrupting chemicals, all of which we're exposed to in the hospital. The WHO puts out a report every year on gender, climate change, and health, showing that women are disproportionately affected by climate events and are much more likely to die from extreme weather events. And we're not immune from this as well. Climate disasters are also healthcare disasters. Out of 100 hospitals who serve catchment areas of 8 million people or more, 45 of them have had to declare internal emergencies due to some kind of extreme weather event, whether that's fires, flood, freezes, which are leading to things like power outages or water outages or evacuations. Most of you are very familiar with this review that was published in 2020. It was one of the first large reviews of over 32 million births, showing that, of course, increased heat exposure and air pollution were associated with negative birth outcomes, including preterm birth and low birth weight. But surprisingly, this effect was found across All geographic regions in the US, and not surprisingly, Black and minority groups had the largest effect. I think it's also really important to look at local pollution as well. This was a study out of California of 5.9 million births, geolocating those births to coal and oil power plants that subsequently closed. So essentially a metric for local air pollution, particulate matter, and some chemical pollution as well. And what they found out happened to births when these power plants closed it, that there was a 27% reduction in preterm birth, which I find is just a really interesting number, because now that 17-OHP has been taken off the market, or the FDA has discouraged the use, this was a very similar result we were supposed to get. But the climate data has been reproduced over and over and over, and those things may actually have more impact than the medications that we aim to give patients. This is also affecting disparities. This was another study out of California looking at 1 million births and Black-white disparities between preterm birth, very preterm birth, and small for gestational age. And neighborhood air pollution was a bigger predictor of these birth outcomes than any other socioeconomic factor, including things like Medicaid enrollee or poverty rate, or whether patients spoke English as their first language. This has been shown in other countries as well. This was published in Nature Sustainability, looking at 250,000 pregnancies that ended in missed AB at 14 weeks or less. In Shanghai, they have pollution monitors around the city to measure particulate matter, and they're able to geolocate patients' home and work addresses to these different pollution monitors around the city to estimate an amount of particulate matter that patients are exposed to. And you can see an increasing odds ratio compared to an increasing exposure to particulate matter when it comes to early pregnancy. And so you might be wondering, well, what does a number like this mean, a number of particulate matter measurement in the hundreds? When there were the Quebec fires, I think last summer, that coated the Northeast, cities like New York City, in one day had particulate matter exposure greater than these numbers. So these are putting patients at a really high risk for early pregnancy loss. And as I mentioned to you, it's not just being shown in reproductive health, it's being shown in other surgical fields as well. Very similar study was done for patients who underwent cardiac transplant and then measured their particulate matter exposure afterwards. And the risk of mortality goes up the more particulate matter they're exposed to. Even in something like bariatric surgery, where you might not be expecting a big effect, they took patients who lived next to major roadways, which is a marker for increased exposure to particulate matter and nitrous oxide, versus case-matched controls who lived further away from major roadways, and compared their outcomes. And they found that the patients who had more traffic-related air pollution exposure had less weight loss, less change in their hemoglobin A1C, and less change in their lipids than those who lived further away from this local pollution. And so moving on more from heat and air pollution into the toxic substances like plastic waste. And as big waste producers, we are creating a lot of this. In general, there's about 220 million tons of plastics produced each year, and about 40% are for single use. And those things break down into microplastics, which become less than 5 millimeters in size. Microplastics have long been found in food, drinking water, human intestine, but it was 2021 when it was first found in human placenta. It was found in all placental portions of maternal, fetal, and chorioamniotic membranes. I thought one really interesting thing that they pointed out in this study was that it was so hard to do this study because there were so many plastic things around the hospital that they had to make sure the placentas didn't touch the plastic, and had to make sure they were using metal. And that just shows how far we've come to with our plastic exposures in the hospital. Microplastics have now been found in many other locations as well, including things like semen and fetal meconium as well. And microplastics have also been found in our blood. This was a study of healthy volunteers from the Netherlands with blood samples, and they looked for plastic particles, and they found things that are very common to us, like polystyrene, the yellow, that's styrofoam, or the blue, polyethylene, that's soft plastics. That's most of what we use in healthcare. And many of these plastics have endocrine disrupting chemicals in them, which we in our healthcare field have been talking about for a long time. But many of these things incorporate things like phthalates. ExxonMobil is the biggest producer of phthalates. They're called plasticizers. They make plastic soft, and they also hold things like color and odor. And they're incorporated into certain medications to control delivery, like PPIs. They're found in up to 40% of medical use plastics. So anything that's soft consider it has phthalates in it, parabens, which are used for their antimicrobial properties and are found in our ultrasound gels and HEPA, and then BPA, BPS, of course, which is in dialysis and ointment tubes and can be absorbed transdermally. And this was just an observational study looking at exposure to EDCs in an L&D and a NICU. And they found that 74% of admitted patients were exposed to at least one EDC. And in the NICU, over half of their equipment contained EDC, and some of these exposures exceeded recommended amounts because the neonate's weight was so small. And finally, I'll submit that what we're doing with our medical waste is racist and hurting communities that we aim to serve. And so many of you have heard about redlining. But what you might not know is redlining was also used to reclassify historically Black and minority neighborhoods from residential areas to industrial zones so that toxic waste facilities could be placed at those sites. And to this day, 80% of toxic waste facilities are still in historically Black and minority neighborhoods. And as the biggest waste producers in our areas, this is directly hurting these communities. So if we want to talk about social determinants of health, I think we should start by simply stopping polluting these communities. And if you want to learn more about this, I have two books to recommend, The Color of Law and A Terrible Thing to Waste, which was written by Harriet Washington, who wrote Medical Apartheid. Really lends the insight into these laws and then also the exposures that patients are undergoing. And so now that I told you all the big bad news, I want to take a deep breath and talk about how do we fix this? Because I really do believe it's fixable. When you look around and see what's going on, a lot of it doesn't make sense. And what I've learned is that the data exists to make evidence-based decisions based on patient safety. And nearly everything that we're doing, particularly in the operating room, is related to culture and incentives, and it's not related to evidence. And I want to show you some of that today. And so as we go through this, I want you to think about a couple of things. I want you to think about how much waste is produced by your most common procedure, even in your clinic, what's going on there, what kind of EDC exposure is going on for your patients and for yourself when you're in these situations. And then what are processes that we're doing that don't really make sense? And then you might have heard the sentiment, well, individual action doesn't matter. And if you make climate change a personal responsibility, it distracts from the impact of industry. But I would argue that we are the industry, and actually physicians are a big driving component of the culture of how we're making purchasing decisions and what's going on in hospitals. So what can be helpful is to distill down even more where our carbon emissions are come from. And that comes from something called life cycle assessments. So this was a paper done at McGee by Cassandra Thiel, who is an environmental engineer. She does these life cycle assessments with different healthcare systems around the nation. And they did a life cycle assessment of hysterectomy. And this is what the data looks like when you do this life cycle assessment. So it can look really busy, but I want to break it down for you because it's actually quite powerful. So each small bar in this section is a different type of hysterectomy: abdominal, vaginal, laparoscopic, and robotic. And then each large section is a different impact on the climate. Things like greenhouse gas emissions or smog or acidification of fresh water or carcinogenic potential. And climate scientists will tell you that they don't know which factor is the most important, but when you put it all together, you can see what is driving the machine, essentially. And what these engineers do is they go into the operating room and they watch everything that's coming in and out, and they take that item and then they measure the entire impact from, again, the cradle to grave, what it took to take it out of the ground and create it, use it, and then throw it away. And this is what they get. And you can see that the overwhelming amount of color on this screen is the green. And what is the green? It is our simple single-use materials, our gowns, gloves, drapes, all of our really thin plastics that are used in the operating room. You can see to a much smaller extent something like the red, which is our HVAC, electricity systems, our purple, which are our anesthetic gases, or the blue, which is even hard to notice. That's our re-sterilization processes, so the impact of the chemicals to re-sterilize. But that looks like nothing compared to all the green. And again, these are just our simple single-use things that are opened, the really thin plastics. And this is probably where we can target the most for reduction. And in fact, the author said from these life cycle assessments that when it comes to laparoscopic surgery, we could reduce our carbon impact by 80% simply by doing a few things. And that's minimizing open materials, stop using heat trapping anesthetic gases, maximizing instrument reuse and single-use device reprocessing, and then reducing off-hour energy use in the operating room. Those are called HVAC setbacks because ORs traditionally are not used 24/7. That's simply letting the temperature normalize and turning off generators when ORs are not in use. And this is something we've heard our entire lives. This is simply reduce, reuse, and recycle. Reduce, reuse, recycle. A lot of focus for our lives has been put on that recycling. And recycling is really important, but it does take a lot of energy to break something back down to its native components and then build it up again. What we really need to be reducing is really need to be doing is reducing, and we need to be reducing the green, which are the excess of single-use supplies in the operating room. And this is evidence-based. There's a couple studies that have come out of COVID showing what happened when some of these supplies went away. And I love this study. This was done at City of Hope, which is a cancer hospital here in Southern California. And when things like their single-use head coverings and masks and foot coverings went away, they looked at what happened to the surgical site infections. They pretty much continuously kept operating because they only took care of cancer patients. They did not have an ER for others to come in. But they did note that patients who came in had more complex cases and were more contaminated because they were presenting later for care. Despite that, their surgical site infections after these single-use supplies went away went down, and it didn't go down by a little bit, it went down by half. And they noted that the biggest impact was probably an increased compliance with hand hygiene. So it's probably really the simple things that make the biggest impact when it comes to patient safety. And all of these other things I've come to call a safety facade. Like they look safe and we're told to do them because they seem safe, and they're actually less safe for patients. This has been looked at from the AORN Buffont recommendations, where they said that's going to reduce surgical site infections. And the Joint Commission came and said you have to pull it below your ears because that's really going to enhance patient safety. And then the fallout of this study showed that not only did it not reduce surgical site infections, in some service lines, surgical site infections went up when hospitals transitioned to the Buffont. So again, safety facade, something that looks safe that's actually not impacting our patients all or maybe harming them. We can look at this when it comes to scrubs as well. And this is important because laundering and re-laundering things unnecessarily uses a lot of water. For example, laundering a single hospital blanket uses 2.5 gallons of water. But this was a randomized controlled trial on OBGYN residents, and they looked at the differences in bacterial colonies based on where their scrubs were laundered and where they got dressed, whether it was home, hospital, home, etc. And they cultured them all up and followed their patients. And of course, there were no difference in colony forming units, and there were no difference in surgical site infections for their patients. It doesn't matter where we're putting on our scrubs, but if your hospital has a policy where you have to change in and out every time you leave the operating room, again, that can create a lot of excess laundering. And because people know I do sustainability, they send me pictures now from absurd processes in their hospitals. And there is a laundering company that is now wrapping scrubs in plastic. So now you're not only enhancing patient safety, but now we're having to throw away plastic, which we know is expensive and harmful. These things don't make any sense. And when we see these processes, we need to alert somebody, use the evidence, and fight against them. This is in line with what the CDC says. The CDC says that surgical site infections come from the patient's own body, and that things like prophylactic antibiotics, skin prep, and metabolic control affect their risk much more than bacteria from OR staff, much more than anything we put on our bodies. So remember this, PPE is personal. It's for you. It's for your protection. Wear what you need for your own protection, but don't overdo it because we think we're doing something good for the patients. And this leads to something that we deal with, especially in laparoscopic surgery, for laparoscopic hysterectomy and the separation of surgical fields. This was an email that went out to the AAJL listserv several years ago, and I saved it because I think it just exemplifies everything that we go through when we're told that we have to undergo a process change. And this doctor says, secondly, we are now also being asked to change gown and gloves after any vaginal or perineal contact during a laparoscopic hysterectomy, change gloves only. If we go below for any part of the case or cuff closure on laparoscopic and abdominal cases, I have a lot of physician pushback from this request, and we can find no evidence to support such a vigorous separation of the vaginal and abdominal fields. And we see proliferation of this, again, in the name of patient safety. If we implement surgical bundles, if we change everything before we close the cuff, or if we change fields, that is going to help patient safety. But the bottom line is this is not really driven by any evidence at all when it comes to changing what we're wearing in the operating room. And this was first studied, this was the award-winning paper at AAGL, I think in 2017, where they took cultures from different sites in the operative field during total laparoscopic hysterectomy at different points in the case. For example, they took cultures after the prep of the vagina and the abdomen, and they took cultures of the surgeon's gloves after placing the uterine manipulator and after the specimen was removed to see if there was really any difference in colony forming units. And to be honest, there was really no difference throughout any point in the case. The only culture that grew out was from the same patient, and that was on the specimen and the surgeon's gloves who had touched it. So if you want to change for soiling and contamination, that makes sense. But look, even after the prep, the abdomen had more growth than the vagina did. And I think one of our issues is that epidemiology drives these policies, but they actually don't come into the operating room, and they're not surgeons and they're not gynecologists. And so I think there's a lot of fear of the vagina and basically these epithelialized or different mucosal surfaces around the body for which there is not good guidance from the CDC. So we decided to create something similar at our institution and simply report on what was going on, because I was trained with a mentor who kept everything as one single surgical field and would go back and forth without changing anything, whereas my partner was taught to keep the fields completely separate. Even the preps were separate and the drapes were separate from the fields, and to not go back and forth at all. So great, it was an easy thing to study. We looked at our different outcomes, and of course, there was no difference in our surgical site infections. There was no difference in any of our outcomes between our patients when it came to total laparoscopic hysterectomy. And this was just published in the Green Journal a month or two ago. So let's rethink these processes. And when you look back to where this comes from, where does this separation at all come from? It comes from an AORN commentary from the early 2000s that said, there's no evidence for this, but we think we should keep the field separate and it needs to be researched further. Well, this is further research showing that we don't need to keep these fields separate. But why does it matter? Because if you have to set up two fields, you're increasing that green, you're increasing the impact of what we're doing in surgery. And this has been looked at in other surgical fields as well. Our hand surgeons have really been leading the way when it comes to surgical field reduction. Some hand surgeons did a pilot of 1,000 cases where they went from a standard 2-table setup, large setup for hand surgery, and went to what they called the lean and green back table setup. And they actually published this as a national bulletin and created a lean and green hand surgery initiative where they estimated that 2,000 hand surgeons in the US doing only 100 cases per year would save $2.3 million and over 1 million pounds of waste. And so how can we extrapolate this to our own fields? What about hysteroscopy, D&C, or cystoscopy? On the left is what I do in the office. I do tons of office hysteroscopy. There's no sterile field. It's not a sterile procedure. The instrument is sterile, but everything else is not, including the vagina when I perform vaginoscopy. Versus in the operating room where, look, we have 2-table setup. We have drapes covering everything. We have gowns covering everybody for the same exact procedure. What we're doing here really doesn't make sense, and we're going to be studying that. Outcomes of our patients who undergo OR hysteroscopy versus office hysteroscopy. And what we're seeing already is that office hysteroscopy even has less complications for case match control, probably because they're not asleep and the uterus isn't being relaxed. So things like that. But the bottom line for our admin is that throwing things away is really expensive. This was a study out of UCSF looking at the things that were opened on the surgical field but never touched the patient and went right into the trash. And they determined it was 13% of their total surgical supply costs, or $2.9 million per year. 13% is more than CMS cuts just for inflation. We could simply not open things that aren't even affecting the patient at all and throwing them in the trash and save a lot of money. And this is one of the things that really bothered me when I moved from Boston to Los Angeles, was seeing how our trash was triaged. And this is what I call the red bag problem. So you see in our operating rooms, it was all set up for biohazardous waste and linen. There was not even an option for regular waste anywhere. And I found out that every single thing that was being opened in the operating room was going into these biohazardous waste bags. And so why does that even matter? Well, biohazardous waste bags have very specific guidelines for how they should be managed from the state. And they are supposed to be either steam autoclaved or incinerated prior to disposal in special waste facilities. So they often have to travel further as well. And because of this, they are extremely carbon intensive and they're extremely expensive, more than 20 times the cost of regular waste. But again, they have very specific guidelines for what should go in. And it's not sterile packaging. It's not sterile wraps that come from the operating room or anything that isn't what is supposed to go in. And what is supposed to go in? Saturated, ringable, dripping blood. These guidelines came out of the HIV epidemic, so they're extremely rooted in fear of blood products. And subsequent studies have shown that red bag waste and regular trash, even household waste, is not any different when it comes to its infectious capabilities. But we do have these guidelines in place. It's for saturated, ringable, liquid, dripping blood only, and all other body fluids are supposed to go into the regular trash. And so we started a test of change at our hospital where we'd simply, and this was in line with our hospital policy, we simply changed out the red bags for clear bags and put the one red bag in the corner where it was harder to use or harder to reach, maybe behind the anesthesia machine, well away from the scrub tech. Something very easy, atomic habit style, making the right thing easy to do and making the wrong thing hard to do. And again, to do this project, I had involvement of a nurse champion, our safety officer, and our nurse educator, who again agreed that we weren't even following our hospital policy when it came to how we were sorting our trash. And it was just a passed down culture from an incident that had happened more than a decade ago to just put everything into the red bags. So we started with this test of change. And this is what it looked like beforehand. You can see in the graph, our regular waste out of the operating room was at the black line, and our red bag waste was on the red line. And this is for one floor of our operating room. We have about eight floors of operating rooms. And this was leading up to the test of change. And then after the test of change, where we educated people on how this works, you can see what happened. There was a rapid and sustained reduction in the red bag waste. And in our first year alone, we saved $115,000. We decreased our regulated medical waste by 52% and diverted 123 tons. And this has continued, and our numbers now in the 3 to 4 tons per month of red bag waste coming out of the operating room. Again, one floor, and this has now been rolled out to the other floors in the hospital, saving the administrators tons and tons of money and saving tons of incineration simply because of education and a process change on how we were looking at waste. And so this is low-lying fruit that can be used to gain traction for other projects as well. So our anesthesiologists saw we were doing this red bag project. They decided to remove their desflurane vaporizers last year. And they found out that they weren't even using the amount of desflurane that they were required to purchase from their contracts. And they saved over $100,000 a year simply by removing the vaporizers and not having that requirement to buy a certain amount anymore. And then just this year, we decentralized nitrous lines. Nitrous is a rarely used gas, but about 99% of it, 99% of hospital use is simply just leaked off into the atmosphere through central piping. And so it should be used more point of care. And so we had those lines decentralized. We started a battery recycling program, making sure we were taking those batteries out of the striker suction irrigators. Our waste contractor was already doing that. And then not using the striker suction irrigators at all when you don't need it, only using it for cases that really need a ton of irrigation. We're starting a recycling program where we're recycling packaging into purple bags, and then reusable sharps containers, something you might not even think about, but most sharps containers are single use. So when they're full, they're simply put into the incinerator just like everything else. And our waste contractor is able to provide these reusable containers. So they take them, empty them, clean them out, and bring us back a clean one. And it actually saves us a ton of money and a ton of plastic waste as well. And then because we were talking about it, our scrub tech said, oh, there's all this stuff in the custom packs that you're not using. These are custom packs for GYN laparoscopy. Look, and we've got multiple gowns and blue towels wrapped in soft plastic and in polyethylene. We've got these plastic basins, which used to be metal and autoclaved in our trays, but now they're just plastic and they're not even that high quality. They're shoddy, they bend, they don't hold heat. And then on the right, our hysteroscopy custom packs have bovies and suction tubing, and our scrub techs were throwing this off before we even entered the room. So things that we didn't even know were going into the trash. So understand what's in these custom packs, which we are paying for, but throwing out immediately these things that aren't even touching the patient. So we're doing a project to reduce what's in the custom packs. And so you might wonder, well, where did this love of single use come from anyway? How did this happen? Well, you can look back to the mid 90s, the late 90s, early 2000s. There's a lot of PubMed indexed articles that are company perspectives, essentially marketing, that says, well, surgeons and OR nurses prefer single-use instruments because they're sterile, safe, reliable, they're innovative in design, and they're always available. And so because of this, you may hear things from your value analysis committee like, oh, we're not going to spend money on capital. It's easier to consign disposables and pass on the costs. And we don't have to sterilize them. And sterilizing is bad for the environment. So disposables are better. But none of this is true. And we saw it blatantly during COVID, where our 30-year transition from reusables to single use resulted in a complete collapse of our supply chain, and not slowly over time because we still had products, but complete because we're completely dependent on this consumption of single-use products. And what's really interesting is that single use is not even a FDA term, it's a manufacturer's term. Single use is a label self-designated by manufacturers who don't want to do reusability testing. This was a great article in JAMA from October of last year. They called on the FDA to say, make companies incentivized to do the right thing, to do reusability testing, because it's very expensive. And for example, since 2000, surgical gowns are 510K medical devices. And since 2000, only 2 applications for reusable surgical gowns have come through, but more than 20 applications for single-use gowns have come through. Manufacturers are incentivized to do this by the FDA. We need the FDA to change how they're evaluating devices, including gowns. It's even been looked at for speculums. You might have heard the sentiment, oh, plastic speculums are better because the stainless steel ones are really bad for the environment. But we can answer this with a life cycle assessment that shows you only have to use a stainless steel speculum 2 or 3 times in a half-filled autoclave tray for it to be better for the environment than a plastic speculum. This is where marketing comes in. I don't know about you. I literally get these emails every single week. I'm like, read the room, guys, know who you're talking to. I get these emails every single week about preventing cross-contamination with single-use speculums. Cross-contamination of what? This is a non-sterile device going in a non-sterile location. Now we've added an LED with a battery and we're throwing these things away. This is money for the companies and really, really bad for everything else that's going on in healthcare. I mentioned that the CDC provides bad guidance for mucosal surfaces, and it's the same thing in anesthesia. Look at what has happened to their laryngoscopes. They went from completely reusable laryngoscopes to now completely disposable, including these handles. This was 1 week of 1 floor of laryngoscopes thrown out. 1 week. This is really, really sad. We have to change this tide here. And it's been studied, of course, when it comes to looking at reusable and reprocessed devices. Systematic reviews show single-use devices, there's no evidence to support them when it comes to function, ease of use, patient safety, transmission of infection, or long-term patient outcomes. And interestingly, the FDA has provided guidance on reprocessed items since 2000. And every reprocessed medical device is individually tested, whereas single-use products are batch tested. So you're actually much more likely to get errors and faulty instruments from batch testing rather than individual testing. And this is where we need to work with our industry partners. I do work with industry. My biggest contribution is saying, I don't want single-use items. I don't want single-use items. And when a rep comes to talk to you, say, how can you make this reusable? If they keep hearing it from us, then they're going to take it back to their engineers and say, we need to make these reusables. It's going to come from changing company compensation rather than commissions based on service. It's going to come from value analysis and considering the entire life cycle of an item and saying like, well, actually, we're not including the disposal price in the price to carry this. Or what if we just made companies responsible for their own waste? Say, yes, we'll carry your device and you're going to have to come pick up the waste. Some companies are starting to catch on and doing this already. And just like the nutrition industry, we should be demanding these environmental impact labels so we can compare apples to apples when it comes to impact, as opposed to just being told the marketing bullets from the companies. The federal government is concerned and they are aware. Several senators last year wrote a letter to the Secretary of Health and Human Services saying that they were very concerned about what happened during COVID with the collapse of our supply chain. And they had 3 pillars of concern. 1, the environmental component from the excessive amount of waste we create in healthcare. 2, the excessive costs, with some costs skyrocketing more than 2,000% during supply shortages. And then 3, the protection of patients and healthcare workers when those supplies aren't available. And so the National Academies put on a workshop about reusable healthcare textiles, which I was one of the committee members. And all of this happened in March. All of this is available online if you would like to learn about the benefits and the processes for switching over or switching back to reusable healthcare textiles, because the government is aware that something like this could happen again. And we haven't really made any changes to mitigate how we would respond. I think another elephant in the room to talk about is the Joint Commission. And the Joint Commission has been asked about sustainability. They've been asked about single use versus reusable. And they say, well, that we don't have the authority to talk about regulations on this. And procurement is a supply chain issue, not one we're able to evaluate for compliance. And they've come out and say that they are committed to sustainability. And now they've included an optional sustainability metric in their certifications. I think that they are distracting from their impact. There's already evidence building for class action lawsuits that against them, just like in the opioid crisis, showing that they've created environmental and financial harm in communities. But we need to hold the Joint Commission at their words. They are checking to see if our policies are in line with what we're doing. So we need to make sure our policies are evidence-based for patient safety and also not overly wasteful. And then we need to push back with the evidence when they're asking us to do something that is completely not in line with policy and not in line with evidence. Health and Human Services did launch a pledge to asking hospitals to pledge to measure, first, just measure their carbon emissions and then reduce those carbon emissions. And so you can look at the QR code and see which hospitals have joined on to this pledge. And if your hospital has joined on, you can go to your administrators, you can go to your sustainability committee and say, what are you doing to actually measure and make change for reduction? And if your hospital hasn't signed on, then you can say, why haven't we signed on? Is this not important to our community when we're serving human health? So what do we need? And where do we start? And let me just propose a few items that I think hopefully can prompt some ideas as you go forward from this talk. We need environmental research projects on your specific patient outcomes. If you take out specimens, test it for microplastics. If you have a different process in the OR, check for surgical site infections afterwards. We need to publish so that we have this evidence. We already have a lot, but more always helps. We need QI projects on best practices for resource minimization. Look at your custom pack, look at your tray, look at what's being opened, look at your preference card, reduce these things as much as possible and see if it makes a difference in your day. Most likely it won't, and most likely it will actually increase your efficiency because you'll have less broken instruments, you'll have less turnover time as people are scrambling, looking around for things. We need partnerships with industry. You're in the Bay Area, you all have wonderful partnerships with industry. You can be a very loud voice to say, this is how we want to use things, and we don't want shoddy single-use instruments anymore. It's not smart or innovative. It's not what we want, and it's very wasteful, and we're running out of space. We need national society practice bulletins and guidelines that are specific and actionable. ACOG has one of the strongest practice bulletins or committee opinions on climate change of any national organization, but we have no guidance on how we can participate in creating that. And so we need these society practice bulletins for best practices. And lastly, we need to petition our hospital leadership with financial savings. The environmental projects are good to do because naturally they save money because we are reducing our consumption. And so these are easy projects to push with administrators because we will be saving money in the long run instead of spending more money. And then study what's been done since COVID. This is just an example of a paper we published. last week. Since COVID, we implemented virtual visits, virtual consults for our patients. We have a referral-based practice, and still to this day, 85% of our consults come in virtually. And we looked at what happened to the carbon emissions of these visits, but also the patient outcomes, and showed that our patients didn't have any difference in outcome, whether they came in person or whether they were seen virtually. But the carbon emissions and even the patient time and cost to get there and park was significantly reduced. So things like this, the things that you're already doing, just publish them. And how do you start? You start by talking to your team and looking at your scopes of influence. And I mentioned working with a nurse champion. Find somebody in nursing who is as passionate about a project that you are. Nursing has incredible infrastructure in your hospital. They have nurse educators. They have people that review policies. We have a safety officer. Partner with somebody who works already in that infrastructure to get support. And again, in the operating room, talk to your team. Ask your scrub tech and empower these people to make change and say, hey, I don't want these things open. If you're the surgeon who walks in and says, I don't want these things open versus the opposite, they're going to respond to that. And then on a bigger level, talk to your health system in your hospital. Ask your sustainability committee, what are they doing? And ask how they are bringing physicians together throughout the organization to collaborate on projects. Because what I found working with the administrators is they are in business and they should be the expert at these projects, but they want physicians to be the drivers. And that's fine. We can be the drivers, and because we can understand the evidence and we can understand the health impact on patients. So ask these people what they're doing. Ask your supplier what they're doing, what kind of green initiatives that they're working on. Ask your group purchasing organization what kind of things they're throwing in that are expiring that we don't need, and find out what your colleagues are doing. You actually have an emergency room physician at Stanford who I met through the National Academies workshop, who is currently working on transitioning single-use isolation gowns over to reusable isolation gowns in the emergency room, doing a really nice test of change there. So find out what your other surgeons are doing. And then, of course, more regionally, ask your representatives what they're doing and initiatives in the local area, and research your candidates to vote. There is a free organization for physicians that you can join called Healthcare Without Harm. They have lots of information online about QI projects and projects you can do just to get started. And they even have a conference every year called Clean Med. And even if you never intend to go, you can look and see how they commit to organizing a clean and green conference, like something that reduces carbon emissions when it comes to conferences. So lots of good information out there that's free for us to use and prompt our ideas. And so I'll leave you with this, that the AMA Journal of Ethics in 2017 said, physicians and health organizations have obligations to use their influence, expertise, and resources to protect health, which includes promoting sustainability. And as I mentioned, I think we can change our industry. We are the industry, we're the drivers, and we can change it. And there's lots of opportunities to do so. So